physiological components to use functional echocardiography if we can, alongside our other routine measures to assess response to therapy and to tailor our management in individual patients. And we hope that using this model, it will translate into improved outcomes in these patients. So I want to thank you all for listening, and I want to just invite you all to join us, if you would like, at the CDH International Symposium, which is usually held every 2 years. And in a couple of months' time, we're going to be holding it here in Glasgow. Have a look at the website, cdh22.com. You'll see the provisional program there and the fantastic international speakers that we have speaking on those different themes. And if you would like to join us and attend, please drop me an email, because for teams within Egypt and in other settings, we have a discounted rate that may be available to you. So rather than registering on the website, get in touch with me and we may be able to support a discounted registration for you. So thank you very much for listening. I hope that's been of interest. I'm really interested to hear your own experience in managing these patients and any questions you might have. Thank you.
So thank you so much, Neil. That was really fantastic presentation, and I think you answered most of the, not most, some of the questions. Do you have any comment, Dr. Hisham?
Dr. Patel, this was a marvelous presentation and marvelous brainstorming about this difficult issue. The use of prostaglandin to open the duct seems extremely rational, both to decompress the right ventricle and to support the left ventricle to improve tissue perfusion. I would like to ask you if there is any study about the renal insufficiency with or without the use of prostaglandin. But apparently, if you use prostaglandin, the renal perfusion will improve, leading to improvement of the acidosis and improving renal insufficiency. Another issue I would like to ask, we have faced the problem of prolonged persistent pulmonary hypertension in some other conditions like exomphalus major, and even after surgery and after improvement, the patient deteriorated repeatedly and was in need, and we continued for using sildenafil for 6 months even after discharge, and this was effective in preventing these deterioration. Do you think this would be an issue with congenital diaphragmatic hernia to continue to use the sildenafil or the other pulmonary vascular vasodilator for a long time?
Yeah, thank you very much, Professor Awad. I really appreciate your comments. And I think on the first question, the prostaglandin use and the effect on renal insufficiency, very interesting thought that I'd have to say we haven't considered ourselves before. There aren't any studies that I'm aware of, and we've been looking at this recently, looking at specifically at renal dysfunction in CDH cases treated with pulmonary with prostaglandin. There are a number of case series that have reported improvement in oxygenation and improvement in pulmonary artery pressure, but none to my knowledge that have looked at renal function. But as we mentioned, we know that acute kidney injury, renal insufficiency is an issue in these patients as well. So I think you've highlighted a really important area to look at in the future. In terms of the second point you made around the management of chronic pulmonary hypertension, both in CDH, but also in exomphalus major, I think we definitely share your experience with that. We've seen patients with exomphalus major with this progressive worsening, severe, and in sometimes cases, fatal pulmonary hypertension. And it's not clear, or one of the challenges, I suppose, both in diaphragmatic hernia and exomphalus, is understanding what the pathophysiology is of that ongoing pulmonary hypertension at the level of the pulmonary vasculature itself. When we treat patients with oral sildenafil, in the majority of those patients, we continue it at the point of discharge and through their post-discharge follow-up. Our patients return to a multidisciplinary clinic at the Children's Hospital here, and as part of that, we would continue to do echocardiographic assessment of their pulmonary artery pressure. As you know yourself, it can be difficult to start to assess pulmonary artery pressure once the duct is closed and if the patients don't have tricuspid regurgitation, tricuspid insufficiency. And we published some data actually a few years ago when I was working in Melbourne in Australia on the use of sildenafil after discharge in CDH at that point. And the median duration of sildenafil therapy, if I remember correctly, was around 150 or 180 days. So many patients were staying on sildenafil for almost 9 months or more, in some cases up to 2 years. What we tend to do in that situation is if the patient is improving and the echocardiogram is improving in terms of pulmonary hypertension, rather than weaning the sildenafil dose, we tend to let the patient grow out of the dose of sildenafil, if that makes sense. So we don't adjust it as their weight increases. And ultimately, we're able to then reassure ourselves that they're tolerating a kind of self-wean and we can stop it later. But it's a big unanswered question of what are the patterns of pulmonary hypertension in CDH, especially in severe CDH, and what is the risk of late pulmonary hypertension and adverse outcome. I suspect there are a small minority of patients where there is significant ongoing pulmonary hypertension, and it may be that actually looking at cardiac function is a better indicator of that, as is done in children with idiopathic pulmonary hypertension and adults with idiopathic pulmonary hypertension, where actually they find measures of right ventricular function and biomarkers like plasma BNP are actually more sensitive measures of the disease severity than the pulmonary artery pressure itself. So I don't know if that helps answer your question. I think it's still a challenge in a number of patients. And sadly, we continue to see patients we're able to get them through the acute phase of CDH, through acute severe pulmonary hypertension, respiratory insufficiency, cardiac dysfunction, sometimes with ECMO, and we're able to repair the diaphragmatic hernia. But then later, perhaps at around, I would say between 4 and 9 months of age, they have just ongoing severe pulmonary hypertension, oxygenation failure that unfortunately leads to late mortality.
Thank you. Another issue about optimizing the lung volume in congenital diaphragmatic hernia, I think it is a very difficult issue because you have got one hypoplastic lung and the other, and many authors claim that when you ventilate, you are going to tolerate a greater lung volume on the contralateral side, reaching the 9th to the 10th rib rather than the classic 8th rib. So such issue of optimizing the lung, how do you do it, such optimizing?
Yeah, I totally agree.
How do you do it?
Yeah, I agree. One of the big challenges that we have is the absence of an accurate measure of lung volume and regional ventilation or regional lung recruitment in these patients. And X-ray is our standard measure, but I would agree that it's we acknowledge that it's a fairly blunt tool. And as you say, counting rib spaces gives us some indication, but it also shows us that we have a differential lung inflation in some situations. So I think the first challenge is, are there any better measures of lung volume? And the answer is at the moment, no, but it's a separate talk perhaps. We are working with some biomedical engineers on different non-invasive techniques that may help us in the future to get better assessment of regional lung volume. In terms of with the limited tools that we have at present, how can we better optimize lung volume? I think it's partly education, and there are a number of, I'm not an expert on neonatal respiratory management and lung ventilation, but the colleagues who are both within our own department and internationally, I think promote good approaches towards the open lung concept, both in conventional and high frequency ventilation, and strategies that we can use to understand when we have opened up a lung and achieved optimal lung recruitment, but avoided over distension. So I think understanding those concepts is quite helpful, but also having an approach of repeated assessment, that rather than just setting the ventilation strategy and then leaving it for the next hours or the next few days, actually understanding that lung disease is very dynamic in these patients and adjusting the ventilation settings if we think there's been a change in respiratory status. But I agree it's challenging, and the lack of a kind of gold standard measure of lung recruitment is one of the big challenges in the management of these patients.
So
thank you for your answer. Thank you for your time. I would be glad to invite you to share with us, to be with us in our next Congress or next the meeting of our society, which will be in May. It will be a pleasure to us to have you with us. So if your time schedule will allow you, we'll be pleased to have you with us.
Thank you very much. I'd be delighted to join you. Thank you.
Thank you.
So thank you so much, Neil, for the fantastic presentation, for your time. Actually, I still have like plenty of questions. Some of them have been answered, but I want really to make a focus on some points, because my colleagues, they have a bit of concern about opening the duct and closing the duct. And actually, there are two paradoxical questions. So one of them was asking, if the baby was born and there is a large PDA as part of his problems, and at the same time, it's total left to right shunt, is there a role here for medical treatment to close the duct? So actually, this was a surprising question to me, but I think it makes sense, and it's important really to answer that, because I've seen like some trials to close duct in term babies if we have no concern about pulmonary hypertension. And the second question, like we want to make it clear, like it is important to keep the duct in the context of pulmonary hypertension. And from that perspective, we need to give prostatin to keep the duct open, exactly as any duct-dependent cardiac lesion. Our main focus is the heart in patients with CDH. So would you please try to clarify that point, please, and make a focus on it? Thank you so much.
Absolutely. I think it's a really interesting question, and it has similarities to the questions around the duct in the preterm infant. I think what we understand, including in CDH, is that the duct can have a different role or a different phenotype at different points in time. And the first situation you describe of a duct with significant left to right shunt is early on in diaphragmatic hernia, is not one that we have encountered very often. I would never say never, but it's a situation that we more frequently see late after repair of the diaphragm in some patients where there's an ongoing ventilator dependence. In the majority of cases in that situation, if the patient's pulmonary hypertension is improved and the pulmonary artery pressure is lower than systemic, the duct will close on its own. But there have been a few situations where the duct has not closed, where we're seeing evidence of a significant left to right shunt as the pulmonary pressures reduce, and we believe that is preventing progress in terms of extubation of that patient. And in that situation, we would think about duct ligation or duct closure, but it's a real very few patients in that category. However, it's interesting because there's been a recent analysis of the diaphragmatic hernia registry asking that very specific, that very same question: how many patients require duct ligation or duct closure rather? And I'm hoping that data will be published soon. And when it is, I can share it with you. And you'll see that in the many thousands of babies in the registry, there are a small number where it has been appropriate or it has been felt appropriate to close the duct. So the second question is when should we keep the duct open? Now, to me, that there are, I mentioned before, but I've a number of criteria for when we open the ductus. So the reason for opening the ductus is in a setting of severe pulmonary hypertension where the right ventricle is failing. and is dysfunctional. And so the first question is the right ventricle, is the right ventricle unhappy? And obviously functional echocardiography helps us to answer that question. The second is the pulmonary artery pressure actually high? Because if the right ventricle is unhappy, but the ductal shunt is predominantly left to right, then in that setting, there's no point keeping the duct open. It's not going to make, starting prostaglandin with the specific intention of opening the ductus is not going to make a difference. And the third question is the duct actually closing? Because in many cases, the duct will actually be quite wide open itself anyway. And all we have to do with functional echo is just keep an eye on it. If it starts to close, if it starts to narrow down, that's when I use prostaglandin E1. So the criteria I use are, is the pulmonary artery pressure elevated to a systemic level? And that will be evident from a bidirectional or a right to left shunt in the duct. Is the duct itself closing or constricting? And is the right ventricle dysfunctional? And if all of those criteria are met, that is when I would start prostaglandin. I would then stop it again if the pulmonary artery pressure is coming down and the ductal shunt is becoming right to left. And in most cases, the duct will close on its own. If the duct doesn't close and that rare situation arises of a significant left to right shunt, that's when you may need to think about the approach of closing the ductus. I don't know if that helps answer your question, but in my experience, the duct either fits one of three phenotypes. Either it's closed and the pulmonary artery pressures are down anyway and the right ventricle is happy, so you don't need to open it. Or it's closing and the right ventricle is unhappy and the ductal pressures are high, in which case you start prostaglandin. Or that much rarer case, the duct is open, the shunt is left to right, and we think it's causing problems, in which case we might need to think about closing the duct, either pharmacologically or with duct ligation.
I like this phenotypic classification. It's marvelous, and I think it makes things really easy and hopefully answer that questions very clearly. It's just that there is another important questions really, because it's challenging when the team starts treating the babies. So the question says, what's the best modality for treatment? Is to start melanorinone IV and then add magnesium sulfate and adjuvant therapy as sildenafil. So it just, we don't have IV, they don't have IV sildenafil, so they use it either sublingual or oral. What
Sure.
would you recommend here?
Yeah. I think the challenge, of course, is these patients have severe pulmonary hypertension. And so it seems logical to say, well, why don't we target all of the potential pulmonary vasodilating pathways and see if in combination we can reduce the pulmonary vascular resistance and improve the patient's clinical status. But of course, the challenge is also that these patients are often hypotensive, they have systemic hypotension, and that the pulmonary vasodilators that we give also have a systemic action and may, by systemic vasodilatation, make the pulmonary hypertension worse. And that also can promote increasing right to left shunt and make them more hypoxic as well. So what we tend to do is, our first instinct, especially in the setting of systemic hypotension and left ventricular dysfunction, is to support the left ventricle and try and maintain a reasonable systemic blood pressure. We're not looking for a very high systemic blood pressure. We just want to maintain it in the normal range or the upper range of normal. So we tend to start an inotrope early on. And as I said, our own choice is usually for low dose epinephrine. And once we've got that on board, often in combination with some hydrocortisone as well, and our blood pressure is stable, then quite quickly we'll add in a milrinone, both to support cardiac function, but also for its pulmonary vasodilating action. If we still have ongoing significant pulmonary hypertension, then at that point we will add in our next line pulmonary vasodilator. In our case, that's sildenafil, but in your own institution, it might be something different if you have different drugs available and different confidence with them. Personally, I've seen the data that shows that in term infants with PPHN, there is evidence of benefit of oral sildenafil, and I've no reason to believe that you don't see the same potential benefits in CDH in the patients that are going to respond to it as well. So yes, we use intravenous sildenafil, but if that's not available to you, and I recognize it's not available in a lot of centers, then to me, it makes sense to try using enteral sildenafil instead. But as you saw in that example case that I gave, we'd started the milrinone and the epinephrine on day 1, and it wasn't until day 2, day 3 that we then introduced the sildenafil. And it's to avoid that risk of systemic vasodilatation and systemic hypotension by introducing too many agents early on, if that makes sense. But I understand why sometimes in the setting of a deteriorating patient, it's necessary to do that. And my only advice would be make sure you're supporting the left ventricle and the systemic hypotension at the same time. I see a question that's just come up, and I'll respond to it because it's relevant right now, which is there a role for levosimendan in the failing right ventricle? So there is a nice paper recently published, again from the group in Bonn, about their use of levosimendan. For those of you who don't know, levosimendan is a calcium sensitizing agent which has positive inotropic effects. Its impact on the pulmonary circulation, I would say, is a little bit less clear, but in the hands of that group in Germany, there's certainly, they've got evidence of improved hemodynamics and cardiac function in CDH. What I would say is, it goes back to the principles rather than the individual drugs. The principles here are reduce pulmonary vascular resistance, support left ventricular dysfunction. And it doesn't matter, I would say, exactly which agents you use to do that. Of course, there are some agents which you shouldn't use, but and which might have an adverse effect. But use the medications that you're comfortable with. Use them in moderate dosage, assess the response to treatment, and avoid excessive dosing, which may have adverse effect, would be my advice. The one other question is the role of vasoconstrictors in CDH. Drugs like norepinephrine and vasopressin. There is some data to demonstrate improved oxygenation and pulmonary to systemic ratios, pressure ratios with use of vasopressin. I am cautious about using vasoconstrictors in the setting of left ventricular dysfunction because I would worry that they could make severe ventricular dysfunction worse. But in the setting of right ventricular dysfunction with reasonable left ventricular dysfunction, one of the theoretical benefits of a vasoconstrictor is that by increasing the systemic pressure, you may improve coronary perfusion or the coronary perfusion gradient to a failing RV. And so in the setting of severe RV dysfunction with normal left ventricular dysfunction, there may be a rationale for using those vasoconstrictors. They may also have a direct effect on the pulmonary circulation. There's some data suggests that noradrenaline has some beneficial effect on the pulmonary circulation, but I would be cautious of using it in the setting of severe left ventricular dysfunction. I hope that's useful. It's a complex subject, and the more you think about it, the more complex it can get. Yeah. But I hope by taking it back to the individual patient pathophysiology, we can have a little bit more of a rational approach to treatment.
Thank you so much, Dr. Neil, for your time and for your actually effort to answer those questions. I have like two questions under two contexts. So one of them was related to the management in the labor ward and use of muscle relaxants after that, pre and post operative. And also, actually, I want to hear your advice, like what numbers we have to stop chasing, because I think this is important, all what we do, because we aim for something, so what we can just be permissive about.
Yeah, so on the issue of muscle relaxation, the practice is actually variable between centers, and in our own center we have an ongoing and slightly historical approach of muscle relaxing patients at the time of intubation especially in severe cases in the delivery room, and continuing muscle relaxation until the time of repair, and then stopping muscle relaxation post-operatively once we've got clear evidence of improvement. A number of centers, possibly the majority, actually don't use as much muscle relaxation as their own centers. And they, especially in the milder cases of CDH, are able to manage the patients without muscle relaxation. If you're doing that, then I'd say there are two important aspects. The first is making sure that the patients are adequately sedated, and that the sedation is helping to minimize the pulmonary hypertension. And the second is having good gastric emptying and continuous suctioning of the nasogastric tube or a plogal tube in the stomach, so that there's no accumulation of gas and swallowing of air by the patient if they're able to breathe spontaneously. I would say that other centers are better at doing that than our own center, and that's why we continue to use quite a lot of muscle relaxation. But I know that colleagues in Rotterdam, for example, and in Germany tend to use less muscle relaxation than ourselves. I don't think either is right or wrong. I think it's just a different strategy. The other question, just remind me of your second question, Omayma.
Oh, I don't remember indeed. No, I was just focusing on another question. I think I was focusing, what numbers we are aiming.
Yes, what numbers? Sorry,
Because this is actually a very big aim today, like what numbers we should stop chasing. Yeah.
So I think the important thing is we're not aiming for perfection. We know that these patients have impaired lung function, impaired pulmonary vascular function, impaired cardiac function. So let's not push them to have saturations in the 90s, to have CO2s in the normal range necessarily, or to have supranormal blood pressure. Instead, let's accept pre-ductal oxygen saturations in the 80s. Let's accept CO2s. I don't know if you use kilopascals or millimeters of mercury, but we would accept kilopascals of 6 to 8 CO2 and millimeters of mercury 45 to 60 with a pH of 7.2 and above. And we accept a degree of right to left shunting and therefore a degree of pre-post-ductal saturation difference up to 10 or 15%. And we acknowledge that these patients are unstable, that in the preoperative period, particularly the first 2 or 3 days of life, they will have periods of deterioration, and that we may need some more sedation. We may need to introduce pulmonary vasodilators and inotropes, but that by doing so, hopefully their stability will recover. And a huge part of the management of these patients is the confidence and the skills of the nursing staff. Because what we see in our own unit is that the experienced nursing staff who are used to looking after these patients know that how to avoid the exacerbation of their pulmonary hypertension by careful management, by avoiding a lot of disturbance of the patient, by avoiding excessive noise and light and the things that can make their pulmonary hypertension worse. They also know that when these patients the other things that tend to upset them are when their diaper is being changed, or if they have a diaper that needs to be changed. And the other aspect is that during the perioperative period, anticipating that there'll be a deterioration post-op and accepting that, and acknowledging that we may have to increase our therapy post-operatively to get them through that post-operative period. So sometimes it's about our psychology around these patients and accepting that we don't want to get the physiological aspects in terms of oxygenation and CO2 clearance into a normal range. We just want to be able to get this patient through the immediate transitional period, stabilize them for theatre, and then support them through a post-operative period within an acceptable range that isn't what we would call a normal range for other patients. I don't know if that answers your question, Omayma. Is that helpful?
Yeah, I think Professor Hisham has a question.
Okay.
I would like to ask about optimization of volume in cases of congenital diaphragmatic hernia. How do you do it? What's the role of pushes of fluid in case of hypotension? What's the cardiac tolerance for this? The right ventricle and the left ventricle?
It's a really good question, and I think it's one of the things that in the current treatment guidelines is possibly something that needs to be addressed in future guidelines, because the current treatment guidelines that I mentioned continue to talk about the use of a fluid bolus routinely to treat the hypotension in CDH patients. But as we've seen from the more recent data, looking at cardiac dysfunction, the mechanism of systemic hypotension in these patients is almost certainly one of, left ventricular dysfunction rather than hypovolemia, unless they have a specific mechanism of hypovolemia, for example, abruption or sepsis that's coexistent with the diaphragmatic hernia. So, and your point is important, that actually, if we give excessive volume in the setting of right ventricular dysfunction and left ventricular dysfunction, we will potentially exacerbate the dysfunction, especially if we try and increase the preload in a failing right ventricle. So our approach is actually to avoid excessive volume and instead to support cardiac function by optimizing ventilation and pulmonary hypertension, but also by starting early on those inotropic agents. And only if we've got a specific reason to suspect hypovolemia or septic vasodilatation in these patients will we give volume.
What about the functional echo in estimating the volume status in case of congenital diaphragmatic hernia?
Yeah.
Sphere vena cava flow, it wouldn't be very reliable. The vena cava filled or distended or over distended with such displacement. If there is hepatic displacement, what are the criteria to be used?
Yeah,
to estimate the preload.
Yeah, I agree. I mean, preload assessment in these babies is always challenging, especially if we don't have a central venous catheter for measuring central venous pressure, which is not routine in these patients in our setting unless they're on ECMO. And as you say, the echocardiographic indices looking at the distensibility of the vena cava is challenging because of the mediastinal shift. And as you know, for those of you who perform echocardiography on these patients, the vena cava is often displaced and difficult to image as a result of that. So I agree, it's challenging to assess volume status in these patients. And sometimes we just have to be a little bit more subjective and look at the right ventricular function and say, well, you know, based on that, how confident do we feel about giving extra volume in these patients? I think on the other side, these patients have severe pulmonary hypertension. So one of the important concepts of management is to optimize their oxygen carrying capacity and their hemoglobin status. So although we avoid volume, at the same time, we are, if we think that these patients have a low hemoglobin, then we'll address that by giving them a blood transfusion. So I think that although we're cautious with volume, at the same time, we wouldn't be too cautious with giving a blood cell transfusion if we think that the patient has a low hemoglobin or is anemic. And we would tend to keep their hemoglobin above 140, especially if they've got oxygenation difficulties.
Thank you.
Thank you so much, Neil. I think this was really excellent, and probably like most of the questions are being answered. Would you mind if I send by email if any more questions, actually, because still some aren't. I just would like to focus also on the last thing here, that we are talking about the severe cases, but there are at least 50% of babies, they shouldn't die, because those ones, they don't have those complex situations. We need to aim for gentle ventilation, not to, stop chasing numbers. So early extubation, early stopping of paralysis, because Yeah, at least. So in 1980s, at the beginning of 1980, 45 years ago, the survival rate was 45% in cases, the overall, with only old ventilators that they are now in the museum, and with pancuronium, and with the system of just hyperventilation. We didn't have nitric at that era, and the survival was also 73% in the isolated cases without congenital anomalies. So actually this is what I was going to talk about it, you know, regarding the history and the major history of and advances in CDH. So I would like to focus here on, like, there are many cases as high as 50% that they do deserve to die, and their management is, I don't want to say extremely easy, but it's not that complicated, especially with presence of echo facilities, the ventilators, the new ventilators, the monitoring, the availability of central lines. So there are many options that were not available 40 years ago. And as I said, the most important thing is the human brains and the human dedication and the human hard work. And I'm sure all of you can do it and improve the survival. So we need to aim at least for 60% within the next 2-3 years to manage this a quality improvement project, not only in Cairo, but all over the country. So I would like to thank you so much, Neil. I would like to thank all the attendees for being with us today. Your questions really enriched this presentation and this webinar. Thank you all the team again who prepared the questions, and thank you Dr. Rabab Alam, who were really the high-tech person behind the Zoom stuff, and she established you know, this connections and the poll questions, so she did an amazing work as well. Thank you Rania again for all your efforts and being with me with the support. Thank you Dr. Hisham. Thank you everybody. Thank you my colleagues in the neonatal unit in the maternity hospital. This was a fantastic evening, and actually I'm so happy by being with you tonight. Thank you Neil so much, and hope you to see you soon in Cairo, you know, like hopefully it will be one day, like.
Oh, I would love to join you all there. Yeah. Thank you again so much. I really enjoyed this, and it's great to make a connection with you all, and I'm looking forward to collaborating with you all in the future. Thank you. And if you would like to join us for the CDH symposium, please just get in touch with myself. Yeah,
right. Yeah, and I can connect you if you lose the email, so I can connect you to Neil, and you will have this discount code. So please try to, you know, probably it's too late now to come to Glasgow, but I will attend virtually as well, so we can all attend virtually. You will have access to the online material for 3 weeks. Is that right, Neil?
For 3 months, 3 months, I'll double check. I think for 3 months.
3 months. So it will be actually, you know, a great opportunity for this. Thank you so much indeed, and see you soon.
Thank you. Really, I learned a lot from this beautiful evening. Thank you, Omayma. It wouldn't have been possible to do this without your great effort, and really it was a marvelous night. And sorry to let you let you spend such time with us for a whole 2 hours. I've heard that it would be a single hour, and we kept you with us a couple of hours. But be sure if you will come to Egypt, we'll keep you talking for much more than this.
Yeah. Thank you so much. It was
Thank you very much.
Okay.
Thank you.
Good evening, everyone. Goodbye.
Bye. Bye.
And please, if you have any feedback, don't hesitate to. And later on, we can talk about A Tale of Two Cities in another occasion. Thank you so much.
Thank you, Maima. Bye now.
Bye-bye.